Good morning. As I'm standing between you and lunch, I will endeavor to make my presentation as brief as possible. Okay. Coming after Mr. Oxley, Mr. Nicholson, and Mr. Rose, I, who have no experience in cricket, feel as though I'm batting on a sticky wicket. Now, what I hope to do is to present the medical side of this whole sick building syndrome story. First thing, I need to get an idea as to who I'm speaking to. How many people here are engineers? Okay, great. How many people are human resources or building owners or just general public interested labor? Okay, fine, good, excellent. So I'm wondering how many of you got lost in some of the terms, VOCs, HVACs, and all the other things. Good, so I'm almost with you. What it is for me as the doctor here is that I am the patient advocate. So people in HR get worried when people send in sick certificates. But the reality is that when somebody comes to my office, they don't come to me and say, I have sick building syndrome. It generally doesn't happen. They might come with a suggestion, but often they're coming with symptoms, and then we have to figure out really what is happening here. Now, I've been assigned some tasks by Lieutenant Colonel Brown, and these are the objectives and the assignment that he's given to me. I'm hopeful that at the end of this presentation, that you would leave here at least knowing a bit more about what the challenges are for us as medical practitioners, as well as for the patients. Because, you know, everybody gets worried and talk about mass hysteria, but I don't think it's mass hysteria. If I'm ill and I don't know what is wrong with me, I'm going to get worried. And I'm sure most of you will as well. What I also want to do is to define the medical issues. And it's not that we sometimes don't know what is wrong with the patient, but the real issue is what is causing it and how do we treat to it. Is it real or imagined? I'm going to throw that out through the window right now. Generally, this is real. Even if you can't hold it in your hand, it is real for the person who's experiencing the illness. And then as far as the spectrum of the illness is concerned, I want everybody to be aware that even though we might all be exposed to the same things, we don't have the same response. So we're going to have a genetic susceptibility, and our responses to environmental threats are going to be different based on our response. So for example, I could be sitting next to Paula in a room and I could cough the entire week and Paula might walk away well. Nothing happens to Paula, but the next person 2 seats down from Paula is going to present to me with a pneumonia, and no one is going to dispute that. But here is, you have people in a closed environment and this person gets ill, and often they end up being women, and I'll explain a little bit about that later on. But what happens is then people say, she's hysterical. And we know that hysteria, the word hysteria came from uterus. So I would like to throw that word out through the door right now, because in reality, when we treat these issues, we need to actually treat each patient as an individual. Now, when Mr. Oxley spoke about health costs and costs to the employer, I want you to know there's no cost that can be put on life. If the patient dies, the undertaker will be paid, hopefully, and the relatives will go home and mourn. So the spectrum is such that some people have really mild disease. Some people just call it an annoyance. The other side of the spectrum is that people become disabled and can even result in death. I will deal with the other things at the bottom of my assignment list as we go through. So I believe that what we need to do first is to focus on the World Health Organization 1948 definition of health. Health is not merely the absence of disease, and that's the first thing that people need to get clear. It is a state of complete physical, mental, and social well-being. And therefore, if you're operating in an environment where you don't feel at your best, you feel overly stressed out for whatever reason. I've got too many deadlines, too many things on my desk. I don't have enough personnel to help me out. I feel as though I'm being bombarded with all these things. I am not going to feel well. I will not perform at my best, right? So we have to take the sick building syndrome, or as some people like to call it, non-specific building related illness syndrome, into context, recognizing that the manifestations are going to be different based on what facet of your well-being is being attacked at one point in time or the other. So the first question that has to be asked, and this is the question that I would ask if somebody's coming to my office, is this a specific building-related illness, or is this the quote-unquote sick building syndrome? Maybe strange question. And I think Mr. Oxley, initially, he had defined what the building-related illnesses were. But it is important to define. The other thing is that we also need, as physicians, to figure out, is it truly related to the building at all? Is it that the guy is smoking 6 spliffs every day before they come to work? Because they might be causing themselves illness. They might be drinking all the time. There may be something else going on that has absolutely nothing to do with occupational sources. And therefore, in our history, it is imperative that we take steps to figure out what is going on, an entire and very precise history. We need to know all the jobs that a person has undertaken, and not only the title, but what they have done in each job. Because somebody might tell you they're a porter, but they might also be responsible for stoking the coal at the bottom of the building. And you've missed that. So when they come with the lung disease, we don't know that it's because they were exposed to something, but we thought they were just pushing around boxes or things in an office building. So I'm going to just choose 3 building-related illnesses that are actually pretty common. The first is one that often presents to me because I am a pulmonologist, which is a big word for somebody who takes care of people who can't breathe properly. So work-related asthma. And one of the reasons why I've chosen to highlight these, by the way, is that in the large industrialized countries, when you have circumstances or conditions within your building that cause people to develop these issues, you can be liable. You can become, so it's not just a matter of that person sending in sick certificates or being absent from work and poor productivity, but it's also the impact on health. And the reality is that a lot of the times, depending on the spectrum of disease that occurs, that person could either become disabled or can end up dying. So for work-related asthma, there are 2 types basically recognized. And what we need to recognize in Barbados, we have approximately 20 to 25% of people who have asthma, is that this is indistinguishable from regular asthma. So you may have someone who's an adult, and all of a sudden you hear that they went to the doctor and came back and they were told they have asthma. And everybody goes, but you're old, so how do you get asthma now? Well, it is that they're exposed to certain things within the work environment that have caused them to develop asthma. So they'll present with the same symptoms: persistent cough, chest tightness, wheezing, and shortness of breath. So what happens is that you have some people who have a new diagnosis of asthma, and that's based on the fact that they've exposed. So for example, for people who bake, they may be exposed to flour. People may be exposed to high molecular weight compounds. They may have glue exposure for people making furniture. So there are different things within the work environment that may actually cause someone to develop asthma. It is important to confirm the diagnosis, and the reason for that is that the wrong advice, just based on impression, because you don't want to go with the most convenient diagnosis, and without objective testing means that we then end up leading to a couple of things. One, leading that person back into the work environment where they continue to be exposed to an offending agent, and this can lead to worsening asthma or death. So when we write letters, and I've done this before, I've written letters on behalf of my patients, and I hope none of you have received them, to say that I'm recommending that this patient should be allowed to work away from the general office environment until we are able to sort out exactly what is happening, because there's an additional risk associated with keeping someone in an unsafe environment. The other thing is, if we are wrong, we're going to unnecessarily remove that person from a job. And that is a problem, because really and truly, if this person does not have work-related asthma and we recommend that this person doesn't work, then we are doing them a disservice. We haven't found the answer, and we are giving them medications that they don't need, and we are preventing them from working. So the onus is on us to really try to figure out what is going on. So typically the history is going to be one where the person coughs, gets shortness of breath, And generally, it's much better when they're away from work on weekends and when they're away on vacation. What we need to do is get the patient to do serial peak flow monitoring over a 2-week period while they're at work and while they're at home and on weekends. And then we do comparison, looking for a drop of about 20% while they're in the work environment. And then the other thing we do is do formal lung function testing. Just quickly show you. So one of the issues, though, with asking people to do peak flow measurements, and this is a peak flow meter, just in case I was talking Greek. It's basically a simple handheld device. It's plastic, and all you do is ask the patient to blow into the meter, and this little gauge moves up based on the strength of the blow. The problem, though, is that if you, for example, have an employee who's not very happy, and they have Dr. Google, they'll realize, well, hold on a second. There might be a secondary gain. I don't want to blow very hard on this thing. So this study from the American Journal of Critical Care Medicine, printed in 1995, showed that almost a quarter of the people fabricated results. It seems as though 8.2% were unable to read the thing correctly, and 13 wrong time. So only 55% actually did it exactly as we asked, or the doctors asked them to do it, and therefore it's not really very reliable, which is why we need to then go the next step and get them to come into the pulmonary function lab and test it, where you have a trained respiratory therapist or nurse there to put the person through the paces of doing the lung function testing. The good news about, as far as work-related asthma, if you change your work conditions and put the person on regular medication to treat inflammation and narrowing of the airways, you will get significant improvement in symptoms and quality of life. Hypersensitivity pneumonitis. This is another one of the specific building-related illnesses. It was formerly known as extrinsic allergic alveolitis, and is colloquially known as farmer's or bird fancier's lung. So, you know, with all the birds flying around, it would not be surprising if you find some people getting some shortness of breath. So when you ask them about their occupational history and social history, you need to find out whether or not they're keeping birds or if they're birds within the environment. So it's, you know, it was scary for that lady when the bird dropped out of the AC duct. But, you know, it might be indicative because it might tell you that there are lots of birds around and you need to sort that issue out. What happens in this case is that patients inhale particles. So they inhale spores from the fungi or from the birds, and these will provoke an allergic reaction. So everyone will not have the allergic reaction. Once again, it comes down to genetic predisposition. So everybody doesn't have a peanut allergy. The same thing happens with people who are so predisposed. If hypersensitivity pneumonitis occurs in the setting of a building or your building, this is an industrial disease. And the thing about it is, it comes in two categories. It's acute and chronic. In the acute setting, the patient presents as if they have the flu. So they get generalized body aches, coughing, and you really have to maintain a high level of suspicion. So it's not enough to come to the doctor once, because the first time you come, especially if you're in the time when they have a flu outbreak, it's going to be reasonable for the doctor to think that it's probably a flu-like illness. Certainly if your symptoms persist, then you really need to get an additional evaluation to look to see if this is a hypersensitivity pneumonitis. In the chronic cases, it can go on to lung failure, pulmonary fibrosis, which is scarring in the lungs, and in 5% of cases, it may result in death. So this is an X-ray of a patient with hypersensitivity pneumonitis. A lot of the times, the X-rays may actually be normal, but in this patient has a lot of white stuff on both lungs. So this is the right lung, this is the left lung. And up here is black, which is what the lung is supposed to look like because it has air in it. And this patient has severe hypersensitivity pneumonitis. Often you have to go on to get a high-resolution CAT scan and also do some blood tests. Now you can see that all of this costs money to the patient. And sometimes they'll opt out. They will not come back because they're thinking, well, you know, I don't want to spend all this money. But certainly if we can find what the cause is and treat to the cause, then the patient will get better. Often steroids are required to produce a sustained improvement. Legionnaire's disease, probably of particular interest to Lieutenant Brown. And I'll tell you why I'm picking on him in a second. But basically, it's caused by a gram-negative organism, which is found in in large bodies of water, essentially. Why is of particular interest is that there was a American Legion convention in Philadelphia many years ago in the 70s, and there was an outbreak of Legionnaire's disease. And after that, 29 of legions died. So it became recognized. And one of the issues is that it grows in stagnant water. So in cooling towers, it can grow if you don't maintain your HVAC, your heating, ventilation, and air conditioning systems. It can happen in water tubs or saunas and spas. You also have to think of it. Now, there have been big settlements in the UK where patients have had Legionella and died. So you have to monitor your water sources. It's when the water is stagnant that you tend to get Legionnaire's disease being prevalent. And here, once again, it looks almost like hypersensitivity, but a lot worse. What you have is a diffuse pneumonia occurring, and often the patients end up mechanically ventilated, and the risk of death is quite high. The treatment for this is antibiotics. So basically, one of the issues with the occupational-related diseases in general is that they tend to be similar in presentation, but it can be rather diverse. So you can see that from the nose all the way down to the lungs, you can get disease occurring. So you might find some of your people are sneezing a lot. They get hoarse, especially when they step into the work environment. And it sounds very fake. I mean, what's going on? How come they seem to be fine, they're talking to their friends, and then all of a sudden they're in here and they become hoarse. But the manifestations are going to be different based on the individual once again. And some people go on to get scarring of the lungs, and then of course cancer is one of the big things that we worry about when you inhale certain substances. So the take-home message really is that the clinical manifestations of lung disease are the same irrespective of the etiology. Mold. Mold is one of the things that's often fingered, and one of the studies I looked at looking at sick building syndrome suggested that mold is thought to be one of the big contributors to sick building syndrome. So this is a picture of Aspergillus. It's a spore-forming organism, and basically it can cause quite significant disease, often infecting people who are immunocompromised. It can cause several syndromes as far as the lung concerned, and in people who are allergic or they can get invasive aspergillosis. They can also develop something known as allergic bronchopulmonary aspergilloma, where they start wheezing and behaving like someone with asthma. Now, the sick building syndrome. The sick building syndrome should be strongly suspected when the following conditions have been met. And I took this from the US Environmental Protection Agency. There must be some temporal relationship between the symptoms and the time spent in a particular building or part of a building. Resolution of symptoms when away from the building. A seasonal recurrence of symptoms. So, I mean, that really applies to people in the States, where you're going to have times where you have heating and cooling of the building, as in winter and summer. And then if co-workers or peers have noted similar complaints. So in the history that we take, we also need to find out if other people who are working with the individual have had other symptoms. And it don't have to be coughing. It could be as simple as having itchy skin. They could be ending up with headaches, poor concentration. There are lots of different manifestations of the sick building syndrome. So these are some of the symptoms, and they're a lot longer. It's a lot longer list, really, when you look at it, but these are the common ones. So there are lot of postulates as to why it occurs. And one of the issues is we can't really pinpoint exactly what causes it. So because in my mind, there seems to be an overlap based on the theories between what causes the specific building illnesses and the non-specific building illnesses, i.e. the sick building syndrome, it would probably behoove every employer to make sure that indoor air quality is good, since that's one of the things that's always being cited, to ensure that the conditions are not conducive for the growth of mold. So therefore, you're going to try to control the humidity and keep it less than 50% in your building. Try not to make it too hot. And electromagnetic fields have been cited in approximately 3% of cases of possible etiologic agents as well. So the whole issue of gender bias, and that comes back to the whole thing about hysteria. When they looked at the populations which are most frequently affected, it tends to be relatively young women who are the primary complaints when it comes to sick building syndrome. And it is felt that the reason for that, though, is that primarily young women work in secretarial sort of services or work in relatively low-paying jobs where they don't have a say in where they sit. They don't have a say in the building design, and they are essentially herded into certain areas, and it's not necessarily correlating with what is happening in the other areas where the management sits. And I had an example here where I had complaints from individuals in a certain building, and when I went down to speak to the building manager, he showed me his humidity monitor in his office, which was sort of partitioned off in the corner from the other people. He says, you see, there's nothing wrong here. What's wrong with these people is that they don't eat well. They don't exercise. So, you have an uphill battle, because when the doctor comes in and starts, because I don't want to just write a letter. It's easier for me to sit down and chat with you and say, I think these are the issues that we are facing. And if we could sort of come up with something, then I don't have to write a letter, or I don't have to so you can understand where we're coming from and what we're trying to do. I ended up getting a letter from head office in Canada, which I responded to. I'm the patient's advocate. My responsibility is to the patient at the end of the day, right? So I think we have to be mindful, yes, if one or two people get ill, or more than one or two, it is going to have an add-on effect. But the reality is that if we fix the issues that are easily identifiable within the work environment, then you remove that from the equation. You've essentially done your part in trying to treat the issues. So really it's a balancing act, and you can't remove the psychosocial environment. So you also have to get an idea as to what that person, and I believe this is probably HR function more than anything else. You have to know your employees. So is this someone who's been a troublemaker all along? Or is this someone who has been a really good employee, never missed a day of work, is always on time? Has something else changed in their sort of milieu? What are the personality traits you're dealing with? Is this someone who's combative, always ready to fight? Because their reaction to what is happening might be a little bit different from someone else. And then remember, and I think Mr. Rose just touched on that, the interplay between indoor pollution and outdoor pollution. So if you take a building and put it next to the River Van Stan, and you pull in air from out there, well, you can understand what rubbish in, rubbish out, rubbish in. There's going to be a sort of equilibrium between the environment that you're pulling your air from. So now this is a graphic showing the building symptom indices. And basically all it is really showing naturally ventilated buildings versus air-conditioned buildings. And you can see that the number of symptoms that people complained about increased with the air-conditioned buildings. So the more air conditioning you had, in other words, the tighter the building was, the more likely it was that you were going to get symptom complaints. Whether or not they were valid clearly had to be investigated, but it's something that has to be borne in mind. And I think this has been beaten into the ground, last well dealt with by Mr. Rose. These are the things that really determine indoor air quality, and these are the things that we really probably should target when we are looking to treat the patients that come with complaints. So I'm almost there. For me, The role of the physician in arriving at a diagnosis involves careful history taking. We need to know everything you've done, whether you consider it to be significant or insignificant, and to determine whether it's a contributor to the presentation that the patient is now making. The physical examination may give some clues as to whether or not this is something that is likely to result in morbidity for this person. And then, of course, auxiliary testing must be done to establish a diagnosis, because you don't want to label someone sick building syndrome as having a sick building syndrome or suffering from it, when it is that they actually have a specific disease that you should treat to and possibly produce a cure or at least ameliorate the symptoms for that person. So, in terms of development of the disease, it's really dependent on the duration of exposure and intensity of exposure, which is why often you'll get a request for removal of the person from that environment. The toxic effects of the inhaled substance is going to be variable, but certainly above a certain threshold, you would expect that everyone would develop something. So, for example, when we looked at the firemen and this is not, well, it's sort of occupational for them, but when the World Trade Center came down, we spent the first couple of years studying the firemen who were the first responders to the World Trade Center disaster. And in the first year, because the firemen were a fantastic population, because they were a body of people who had lung function tests done every single year as part of their occupation and employment conditions. What we realized is that right after the World Trade Center came down, there was a drastic change in their lung function, in terms of a lot of them developing obstructive lung disease. So they started to behave like people who had asthma. And this was from a single large exposure to substances within a building. And over the next couple of years, when we repeated the studies, they continued to show a longitudinal decline. So they continue to show decline in lung function. So can you imagine someone sitting in an office for the last 35 years, being exposed to something that's not sitting right with their lungs? Over time, it can have a deleterious effect on lung function. And they may not complain at the beginning, but as they start to get short of breath, then at that point in time, the shoe might drop. And this is more of the same. It's just demonstrating the same sources of pollution in a typical office setting. So for me, prevention is always better than the cure. We might not get any money, we might not get any patients, but I'm sure that when the building owners go to the architect first to get a building design, and then they go on to the engineer, they have no intention of making sure that the occupants ended up at the doctors. So I think good design and working together will help in terms of solving this issue. Where possible, we must limit exposures. And if it is at all possible, so for example, if you own multiple buildings and your employee can do the same thing in another building, consider if it is possible to transfer to alternative work site, even if temporarily. And then what we do is to treat the symptoms based on the presentation. So my take-home points, the first one is for the doctor, so we need to take a proper history. We're going to do the diagnostic tools. We are going to advocate for the patient. You guys might get upset, but the reality is if the patient is your relative, you're going to want us to advocate for them as well. All the complaints should be addressed seriously. Don't dismiss them, because the ones that you dismiss, every now and again, there's going to be one that's going to come back to bite you in the butt. In some cases, what we have is an overlap between the same agents which are implicated in building-specific illnesses and those in sick building syndrome. And therefore, because we know what some of those things are, we can deal with those. These are my references, and I thank you for your indulgence.